I'm glad to see that people are still conscious. Sitting. After a long, exciting day, I think we had a lot of discussions, and since most of us have a keen interest in HIV, so we managed to stay awake. I'm going to talk about a bit of the harm reduction, the policies, challenges, future plans. The presenter before me actually beautifully covered a lot of the challenges and the issues that we seem to have in common. There are ways ahead that we need to find out how to tread on that delicate road where we have the policies, we have the legal issues, we have the social issues, and then we have the health of the people, who should be a priority. Will somebody be moving the slides, or will I be able to have it from here? It's working, thank you. So basically, just a bit of a revision or recollection of what we were talking about. Key populations are pivotal to the HIV. They're actually central to our response. They guide the epidemic, and then they guide our strategies for infection control. Why are they very important in HIV? They're very important because apart from the disease and the risk, there's also strong stigma, there's discrimination. There are barriers to healthcare that are different from what the general population or other individuals face. And then they're ostracized from the mainstream society. They're kicked out of their homes, their families don't accept them, they don't own them, they have nowhere to go, so they enter into that vicious cycle of destruction and lost. Harm reduction services are essential to HIV programming, whether it's for people who are on treatment, whether it's for people who are engaged in high-risk behaviors. What's the ultimate aim of these harm reduction services? Why is there so much of emphasis on these services? It's because at the end of the day, we want to reduce infection transmission. That's one of the keywords. We also want to minimize the negative consequences of high-risk behaviors, especially drug use. Consequences like crime, consequences like self-destruction, consequences like harm to others, consequences like being a burden on the society. They're not contributing anything. They're rather a challenge for our health system. Then we create a demand for uptake of prevention services, a demand for testing. We're not telling them that shut yourself out, don't engage in a risk behavior, but we're actually giving them an option to take up services where they can actually remain safe, healthy, and enjoy what they're doing. Improve ultimate health outcomes. If you have a person who's engaged in a high-risk behavior, the person is taking up necessary prevention precautionary measures, his health or her health will remain intact. And then also, another key aspect that we do not seem to be addressing is the mental and the mental health and psychosocial well-being of these people. And that's the cornerstone that revolves around our programming and calculating its impact. So, around the world, there have been now 109 countries that actually have explicitly supportive programs for harm reduction. They recognize that harm reduction is an essential component of programming that should be there. 88 countries globally are implementing at-scale OMT programs for drug users. Then there's an increasing number of countries that are actually coming towards the concept of having drug consumption rooms. Like we have drop-in centers, we have community support centers, so they have drug consumption rooms where people can take the drugs that they want under supervision. Then they're also engaging in peer distribution of naloxone and other maintenance supportive therapy to handle overdosage. So harm reduction supportive measures, in addition to focused measures, also focus on certain social aspects, like providing them with accommodation, providing them with some sort of drug quality assurance mechanism so that the drugs they're actually using in the streets are of some minimal acceptable quality. They are free of lethal or toxic adulterants. Then we have overdose prevention and reversal mechanisms to meet up with that drug overdose. And then we also have psychosocial support and information on safe drug use for the individuals. So what it actually requires, I think, on the first hand is our acceptance that drug abuse is a problem. Do you agree? It's only when we start accepting that it's a problem that we're going to think of how to resolve it. So harm reduction services, their scale up, making it part of the regular program still remains a challenge. Okay. So what does the global strategies have to say, particularly about harm reduction? They say that the 90% of the people who inject drugs, they should have access to harm reduction services. 50% of them should have access to OMT, 80% to prevention services, 30% to testing and treatment services, and 60% should be led by societal enablers for people who inject drugs. So it's actually the communities, it's actually the peers, it's actually the people who are in different phases of drug abuse and rehabilitation who lead these programs. But there's another point that I'd like to highlight again. It was rightly mentioned earlier that apart from injecting drug use, we have growing evidence of other substances that are being used. Some of our CBO partners are over here. Chemsex, that's been discussed most recently and very highly in a few of the sessions. So what about overlap of sex and drug use and drug abuse other than injectable? How do we mitigate that risk? So our harm reduction strategies again need to evolve. Harm reduction services for people who inject drugs in particular these are, instead of like, me talking, we can just engage, do we have peer-led or community-led or drug user-led programming? We do and we don't. It's among the key populations, they're one of the acceptable populations across the society. So we have rehab centers almost everywhere that work with different phenomena. But are they actually led by the drug users? Do they promote the feelings, the sensitivities, the challenges that the drug users face while accessing, availing, and then recovering from those services? Some of the interventions that have been globally promoted include promoting auto-lock or one-time, lower dead space syringes or auto-destructible needles that can be used so that infection transmission risk is reduced. We can have a package of injection equipment to support safe injection drug use. Overdose management. Then we have gender and youth and key population sensitive and contextually appropriate services, because we in Pakistan have a very challenging environment. What may work in a lot of the other countries becomes a challenge for us to adapt. Then we have, like the speaker earlier discussed, engaging with law enforcement agencies, engaging with other stakeholders, engaging with the religious sectors. A multi-sectoral approach, how do we go about it? That is a challenge. When do we start educating our youth? When do we start educating our children about drugs and substance abuse? That's an issue. This focuses on a lot of specific interventions. We have health interventions that include on commodity distribution. We have the hardware packages like the needles and the syringes, the condoms and the lubricants. Then we have self-test kits. PrEP has been discussed in the morning. And then we have structural interventions. And I think structural interventions are the interventions that need to be put in place to make our health interventions implementable and practicable. Supportive legislation, policy, funding, that's critical for an effective program to be implemented. Addressing stigma and discrimination, having the communities to be empowered, and then foremost, ensuring the safety and security of our implementers. We have so many of the polio workers being killed around. So, do we want to put our implementers at risk for actually delivering key services? So many of our community workers are picked up and put in jails. They're doing a service. So I think the structural interventions and using this forum to focus on structural interventions and ensuring that our program implementation becomes easy needs to be done. Okay, I sort of lost the slide. So harm reduction services, what's the ultimate aim? Why is it significant? Because we've always seen that our health approach has been therapeutic. It has been clinical. We feel that the medicine, the pill, is the cure for everything. But that is where you're dealing with the patient. Why are harm reduction services essential? So this is just sort of a couple of graphs that I've put in. If we have good harm reduction services in place, do you think our graphs would look like this? No. I think we're going to have some sort of a downward trend because ineffective harm reduction services actually result in increased infection transmission. When we talk of HIV, I think talking about the 95 targets is critically essential because we're linking harm reduction to treatment. If anybody from the audience can have a look and interpret this graph, I think all of you know it very well now. Would anyone like to interpret it? Any volunteers? Okay, energy कम हो गई है. ठीक है. So what we do is, हमारा जो harm reduction package है, एक तो prevention को control कर है, लेकिन testing उसका core element है. फिर linkage to treatment उसका core element है. So if we see over the last 5 years, 10% progress हुई है in people who have been tested and they know their status. It's not good enough. So we need to revisit our slides to see what interventions do we need to put in place to improve this graph. Some of the challenges that we face, suboptimal coverage of the programs, the quality of the programs. We have persistent socio-legal barriers in accessing prevention, treatment, and harm reduction services. We have operational challenges. We have difficult to reach communities. Then we have an overlapping risk of high-risk behaviors. Like I mentioned, you've got chemsex coming in. You've got people moving from injecting to other drug use. There's a migration within the drug use categories. And stigma, of course, prevails. So what should we do? Advocacy, awareness, sensitization of different sections of the society about harm reduction services. Increasing government oversight, monitoring, regular evaluation of harm reduction programs to tailor them to the needs and requirements of the populations, to review their impact and maybe redesign for better outcomes. The conventional strategies might not work. You need to come out of the box to think. Strengthening of our programs. There are so many people working with data, playing with data, using that data to guide us, to monitor trends, to see what works and what doesn't, and how can we improve. We had a lot of discussion of PrEP. OMT, self-testing, and then co-infection management. These are areas that we need to focus on. Providing services in special settings like prisons. So we had some very interesting discussions on co-infection management. We had them on PrEP. There's a growing incidence of co-screening among the key populations. We need to focus on referral and linkage.